Welcome to Echocardiography lecture series. This is lecture 15 about stress echocardiography. This lecture is a bit lengthy, but it's very important. There is a lot of indication for stress echocardiography. The classic is detection of ischemia and viability. However, non-ischemic indications are growing and include valvular heart disease, diastolic dysfunction, even congenital pulmonary hypertension, etc. We'll start with the stressor type. We have two main stressors we use in echocardiography. It's either exercise or pharmacological stress echocardiography. We start with the exercise echocardiography. So exercise is always the preferred mode of stress we use in echocardiography. It is almost the preferred one in most of the indication, with only few exceptions. Since it is physiological, it correlates with the patient's symptoms, besides it provides other prognostic factors. So, for example, the exercise capacity and blood pressure response. Now exercise is either performed on a treadmill or on a bicycle. Treadmill exercise is widely used, and it has much more clinical experience than the bicycle. Treadmill exercise usually have a higher rise in heart rate, longer exercise duration, and maximum workload as compared to the bicycle. The main disadvantage about treadmill, however, is you have a limiting scanning time of 1 to 2 minutes post-exercise with limiting image obtained. So we will take only the relevant imaging, mainly is for ischemia or whatever is the indication. We use Bruce or modified Bruce. However, for the bicycle, as you can see here, is a supine bicycle or semi-recumbent bicycle. It has the advantage of image acquisition during exercise that will give more scanning time, that allows for more images, and hemodynamic data can be acquired. So exercise should be terminated when any of the following is present. Patient cannot tolerate the exercise anymore, either is having symptoms or exhausted. Now, severe hypertension during the exercise with systolic blood pressure more than 220 or diastolic more than 120. Symptomatic hypotension with more than 40 millimeter decrease in systolic blood pressure. Significant arrhythmia, SVT, AFib, frequent PVCs, and second or third degree AV block. Or if there is also evidence of ischemia, significant evidence of ischemia, either more than or 2 millimeter and more of SC segment depression below the baseline, or you already found your answer and there is a new or worsening regional wall motion abnormalities. Exercise should also be stopped when you reach your endpoint, or your diagnostic endpoint. So either the patient already reached the maximum workload, or there is obvious ECG positivity or obvious echo positivity or severe chest pain, or are diagnostic endpoint. For the pharmacological stressor, the main stressor being used is Dobutamine. However, for vasodilator, it's still used and it's being used, but in less frequency. In general, if the indication is ischemia, we have to take certain views. Left parasternal long axis views, left parasternal short axis at mid-level, where you see, of course, this is mid-level, you have to see the PAP muscles. Apical 4, 2, and apical long axis or apical 3 views. This is an example here you can see for the stress echocardiography, and you can see the images side by side. And because we used here Dobutamine, so you can see the resting image and then the low dose, and also the peak dose and recovery. In treadmill, however, you cannot use a low dose because the patient will exercise until he reaches target heart rate, and then you will take the images. So there is no low dose. However, in bicycle, there is a low dose. Around 25 watts is considered a low dose for exercise, so we can take the images at 25 watts. Using an ultrasound enhancing agent is recommended when 2 or more segments are not adequately visualized, like any other indication for echocardiography. And when used, you have to use it in all stages. You will start from the baseline, low dose, peak, and recovery, because you need to compare apple to apple. You cannot compare one with contrast with one without contrast. So for the best result, you use it in all the stages. Now, again, we use the standard 16 or 17 segment. We have normal or hyperdynamic. We also say hypokinetic or tardokinetic. So again, if the timing of the contraction is being late, so after the end of systole, we call it tardokinesis, and we deal with it as ischemic, like the hypokinetic. Also, there is the akinetic, dyskinetic, and aneurysmal. The same we use for resting echocardiography. For stress interpretation, a normal stress is defined as normal LV wall motion at rest and peak exercise. So no wall motion abnormalities during or at peak exercise. Even the LV should be hyperdynamic. For the fixed wall motion, you have wall motion abnormalities at rest with no much change during or at peak exercise. Positive stress echo, when doing exercise, we consider positive when there is a new wall motion during exercise or at peak exercise, or worsening of wall motion at peak exercise. However, in dobutamine, we are looking for the biphasic. Biphasic is when at low dose there is improvement of the wall motion. So the wall is viable. We define low dose from 5 to 20 mic per kg per minute. And then at a higher dose, there is a drop in wall motion. So then we call this the biphasic response, and we consider it positive for ischemia with dobutamine. RV function should not be forgotten. Also, we have to check for it either by TAPSE or fractional area change. LV, EF also has to be checked and documented. We look for contractile reserve. A normal contractile reserve is an increase of 5% or more in EF during exercise. Similarly, we have a normal GLS, which is an increase of more than minus 2%. So for example, if baseline is 18 or minus 18%, during exercise it became maybe minus 21% in GLS. So this is a normal response or normal GLS response. Now let's see some study interpretation and see how we can interpret this echocardiography. So if you look carefully here, this is the baseline. Everything appears to be normal. This is a 25 watts, so it means it is a bicycle. So we don't see much of wall motion. Everything is the same. However, this segment here, the infralateral segment, is more hyperdynamic compared to this segment. Now we continue with that. Now the anteroseptal segments now become akinetic, is not moving as much, and also that continued into recovery. So we did not wait here. Maybe the patient had more symptoms and we had to end the study and shift the patient to the emergency room. Same patient here. If you look carefully, you will find even at low exercise, the patient will start to show some abnormality. Here at the apical septum, you start to see hypokinesis, and at peak, it becomes even akinetic, and it continues to during recovery. However, because the patient had a chest pain, we had to stop at early recovery, not waiting, and send the patient direct to the emergency room. Another case. Now here you can see even at low exercise, even patient did not reach the 100, he's having hypokinetic, severe hypokinetic anteroseptal compared with the resting images. Peak, no much in peak, because we already got a positive study. We have to terminate. Once we terminate and we took the recovery images, now everything returned back to normal. As I mentioned, you have to take long axis as well as short axis. So this is the same patient with the short axis. And then you can see here the septum, the whole septum become akinetic compared with the resting and even recovery. More case study for ischemia detection. See, this is normal augmentation of the segment, normal augmentation. So you can see LV now is hyperdynamic, which is normal, particularly at low exercise if there is no significant ischemia. But now here, if you look in the short axis, I like the short axis because it showed you everywhere, 360 degrees of the heart, except the apical. So you can see here that the anterior and anterolateral wall become hypokinetic. So compare this peak exercise with recovery and compare this with the resting. So it's always good to have it, to have a system that shows you side by side each stage of stress echocardiography. Again, as we mentioned, contrast or ultrasound enhancing agent can be used, and if used, should be used from the baseline, and low dose, peak dose, also recovery for the best of the comparison. Now we will shift to viability. Viability is frequent indication of stress echocardiography. It is performed to assess akinetic segment response. Scarred segment, which is defined as less than 5 milli segment, is no use to do viability for a scarred segment because it's already scarred, non-viable. Definition of scar should be less than 5 milli. It's bright, and it's also akinetic. So if you have all that three attributes of a segment, so it means that segment is scarred, which is not viable. Now, the main echocardiographic stress protocol for the viability is Dobutamine. Usually we use Dobutamine, and low dose is sufficient, up to 20 microgram per kg per minute. Other stressors have been applied, including exercise. Now, compared to nuclear modality, echocardiography is more specific but less sensitive, as it requires more than 50% of the myocardium to be viable. So if this is the heart, if your concerned about that segment, for example, more than 50% of myocardium here has to be viable to see effect with dobutamine. Less than that, you might miss a viability, but you can detect it with nuclear medicine. Now, by 20 or by the end of the low dose, if no improvement of the akinetic segment, so initially if the segment is contracting, even hypokinetic, it is viable. No need to do viability. But if it is akinetic and until there is no improvement at a low dose or worsening of wall motion at any dose, then the test should be terminated. If LV function, now if that LV function improved or that wall improved, now it is akinetic and then become hypokinetic, then you can continue your stress beyond the 20. And we will see that in the coming slides. So in interpretation, either it is viable but non-ischemic. So you did viability, you did not stop at 20, you continue all the way to 40 or until you reach your target heart rate, and there is no evidence of ischemia, so it's interpreted as viable non-ischemic. Can be viable but ischemic. So you reached the 20, you saw an improvement, you continued until you reach your target heart rate, and then there is a decline in the function. So there is a biphasic response. We call it viable but ischemic. There is no improvement at all. It is not viable. So again, we start with a 5 and keep increasing. And also with dobutamine, at every stage, we have to take images. We cannot stop. So if you you start with a 5, by the end of the 5 or after 2 minutes, you start taking your images. At 10, also you start taking your images, because if you see worsening of wall motion, then you have to stop. So to look for worsening, you have to check with the echo. Even if you don't record it, but you have to look. Now, as it mentioned, if there is no improvement by the 20 now, you stop. If there is worsening, you stop. Now, if there is improvement, you can continue maybe 30, maybe 40 until you reach your target. If improvement is sustained during that higher dose, so it is viable and non-ischemic. Now, if that improvement starts to worsen, so it is viable and ischemic. So look at this example here. This is scarred myocardium, thin, akinetic, or even dyskinetic, bright, and not moving. So the definition of a scar. Now this infralateral, you can see here some thinning here, but it's not a full thickness. So it's subendocardial scar. There is some scar, but not everywhere. But with a low dose, you can see improvement also in that infralateral wall at low dose. Now at peak dose here, it worsened. So that one here is better than the one here. Then you have the recovery back to the baseline. Same patient. Septum scarred, non-viable. So this is anterolateral wall here. Viable, we don't see much of ischemia, but in infralateral here, infralateral become worse. Same patient again. Lateral, now here if you look at the anterolateral, the full length of anterolateral here, you can see some improvement compared to baseline. And then that improvement at the peak dose, it is gone. It worsened. And then, recovery, it improved a little bit. So that even the anterolateral here is viable and ischemic as well. Okay, inferior wall, no much improvement, no much improvement, the same. Anterior, the same, no much change. So the conclusion, or they reported this study as scarred septum, non-viable apex, ischemic infralateral, anterolateral walls, and there is no contractile reserve. So we said contractile reserve is increase of more than or equal to 5% and more in EF, and this is something very important and has a lot of prognostic values. Now we'll shift gear to diastolic stress echocardiography. So when to do a diastolic? So if you have unexplained shortness of breath with a baseline grade 1 diastolic dysfunction. So if the baseline is absolutely normal, it is unlikely that this patient's symptoms is due to diastolic dysfunction unless he has some ischemia. So for diastolic dysfunction, because now if it is grade 2, evidence of increased LA pressure, grade 2 diastolic dysfunction, this is the one that will cause symptoms. So we want to see that maybe patient will come to your clinic and he's symptomatic. When you do the echo, it's grade 1. So grade 1 should not give you any symptoms, but you're doing the echo only at rest. So we will exercise the patient. Of course, there is no Dobutamine at all for this patient. And preferably we do the bicycle because it gives more time to do scanning. Usually we start the scanning at a heart rate of 100 to 110 beats per minute. We measure E, E prime, septal and lateral, and the peak TR jet. Now, we need to see separation between E wave, mitral inflow, E and A. So usually you start to identify the E wave at a heart rate between 100 to 110. Otherwise, if you do it at a higher rate and start doing your measurement, you might get a single wave and then you don't know which one is E, which one is A. So you need only a little bit of separation just to identify the E wave. You don't need a complete separation because we don't care about the A wave here in diastolic assessment with stress. In this example, you can see that at a heart rate of around 129, there is a single wave, mitral inflow wave. So you don't know the E from the A. And around 93 beats per minute, you start to see separation. And then you can measure the E here. Same thing for the E prime. Here you see a single wave, you cannot identify E prime from A prime. But if you wait until heart rate reaches around 100 to 110, then you can identify the E prime. In normal people with exercise, E will go up. Also, E prime will go up. So the ratio will continue to be the same. But people with diastolic dysfunction and bad diastolic dysfunction, the E will go up and the E prime will not change much, even might go down. So the ratio now will increase, E over E prime. Interpretation. So we call it abnormal diastolic stress if all of the following are met. So you need an average E over E prime more than 14, or the septal more than 15, peak TR more than 2.8. Of course, you can go back to diastolic dysfunction. And then, of course, baseline, you need to have some sort of impaired relaxation. So septal E is less than 7 or lateral less than 10, which is impaired relaxation to start with. Now, normal is when all of the following are met. The average is E over E prime less than 10, peak TR wave is less than 2.8, and of course you can have a gray zone somewhere in between that is maybe not. Now for the hypertrophic cardiomyopathy, the indications are you're assessing for LVOT obstruction in symptomatic patient with P gradient less than 50. So patient symptomatic, you want to find if with exercise the gradient can be more than 50. Also, you're assessing functional capacity and for risk stratification. So exercise is the only accepted stressor. Dobutamine has no role at it. It is not physiological and it can cause LVOT obstruction even in normal people. Treadmill or bicycle are accepted exercise modality. Unlike other exercise modality where you might stop the beta blocker, but here you cannot stop the beta blocker and should continue because the patient came to you with symptoms and you want to see the symptoms with his current medication, including the beta blocker. The parameters to look for are LVOT gradient with a continuous wave Doppler, E over E prime. You look for MR with a color Doppler, TR peak velocity, and ejection fraction. In interpretation, we consider a significant LVOT obstruction with a peak gradient of more than 50 millimeter of mercury, or blunted or drop in blood pressure. However, symptoms can be there due to diastolic dysfunction or worsening of the MR. This is why we take the E over E prime and we have a look at the MR as well. So worse prognosis if there is obstruction of the LVOT, blunted contractile reserve, we know that already, wall motion abnormalities, there is some ischemia, maybe relative to the increase of wall thickness, significant ST depression, hypotensive or blunted blood pressure response. Now we'll shift to heart failure. In heart failure, first we need to know what is contractile reserve. We already talked about this. The expected is more than or 5 and more % increment in EF and more than -2 increment of GLS. That is a normal contractile reserve. Now, flow reserve is something else. It's defined as increase in stroke volume more than 20%, more or equal 20%, and we use that flow reserve in aortic stenosis and low gradient severe aortic stenosis. So now in patient with normal EF in heart failure, so patient with normal EF absent contractile reserve is a marker of latent systolic dysfunction and subclinical cardiomyopathy. So something is cooking. Patient with dobutamine preserved contractile reserve has a better beta blocker response. So because dobutamine is beta agonist, so the more response to dobutamine, you have more beta receptor, and then you can expect to have a better response to the beta blocker and better improvement in EF and better survival with fewer hospitalization in heart failure patient. Now, contractile reserve can help to distinguish ischemic from non-ischemic cardiomyopathy. So non-ischemic cardiomyopathy more likely to have contractile reserve with stress. However, if it is ischemia or secondary to ischemia, you don't expect improvement with stress. and instead it might worsen. MR severity have a dynamic nature, and in equivocal cases such as non-severe MR with symptoms, exercise echocardiography can be helpful in assessing dynamic MR and also regrade the MR. The parameters we need for exercise echocardiography for MR is MR, color Doppler, ejection fraction, TR velocity, PISA, of course, for MR quantification, IVC diameter for RA pressure estimation, and TAPSE. Now, markers for poor prognosis in MR, if there is increase in severity or there is a dynamic pulmonary hypertension. Now you have more than 60s or worse prognosis that you need to act upon. Abscess of contractile reserve. So you expect that with correction of MR, EF might drop. TAPSE, also below 18, is a marker of poor prognosis. So let's see this example. You can see here a myxomatous mitral valve with significant bileaflet prolapse with some mitral annular disjunction. Same thing here as well. This is with the color. All those are resting images. And then when we quantify, it quantifies as moderate MR with a PISA. Pulmonary, systolic pulmonary artery pressure is within the normal. Now with exercise, we try to re-quantify the MR and we did the quantification with the PISA. Effective regurgitant orifice area is the same. There is no much increment in the regurgitant volume. Tiny bit increment in the pulmonary pressure. And the contractile reserve is there. So it was reported as good exercise tolerance with moderate mitral regurg without significant increment in exercise. So it was done for a symptomatic patient. But look, patient exercised for 12 minutes and achieved 100 watts, which is good. So the patient might not be really symptomatic because he did a good exercise. Now for aortic regurgitation, we do stress or stress echo to reveal symptoms in severe asymptomatic aortic regurg. It is not for regrading because you cannot do regrading. What will happen with exercise? Most of aortic regurg occurs in diastole. So with exercise, diastole is shorter. So aortic regurg will be shorter, will be less. So it is not for regrading. Now, but lack of contractile reserve predicts LV systolic dysfunction at follow-up and post-operative. So there is some indication, but again, it's not for regrading aortic regurg. Mitral stenosis indications. Now you need to assess symptoms in severe asymptomatic MS, defined as less than 1 square centimeter. Now, the American guideline also defined severe MS as less than or equal 1.5 square centimeter, and the European still less than 1. But In the stress echocardiography guidelines, we need to assess symptoms in asymptomatic patient reaching a valve area of less than 1 square centimeter. Also assessing symptoms and hemodynamic consequence in pliable valve for balloon valvuloplasty and mitral valve area between 1 and 1.5. When planning for pregnancy or major surgery, it's nice to exercise if the area is between 1 and 1.5, and reassessing MS severity in symptomatic. Patient symptomatic, but your measurement is not severe, so more than 1.5. So it's nice also to do exercise, so you might regrade the patient as severe now. We check mitral inflow with the CW, TR with the CW, and IVC diameter for RA pressure estimation. We call mitral valve, or we regrade mitral valve as severe when the mean gradient is more than 15 with exercise or more than 18 with dobutamine, and systolic pulmonary arterial pressure more than 60 with exercise. We have here a case study, 40-year-old rheumatic heart disease with MS. There is symptoms, and the area, mitral valve area, is 1.6, but there is symptoms. We're not sure, so we are looking to regrade this to severe. So we can see here rheumatic MS with a doming and all the feature of rheumatic. You can see here also flow acceleration and turbulence of flow during diastole. Some MR is there as well. Now, baseline echo with a heart rate of 68, we got a gradient of 9.5. With a heart rate increased to around 100, now we have a mean gradient of 21. So that alone will regrade mitral stenosis to severe. So this is the mitral valve area with a 3D TEE, and I think 3D is the best way to estimate mitral stenosis with 3D planimetry. And this is after balloon, we got an area of 1.9. Aortic stenosis and indication for stress echocardiography, low flow, low gradient aortic stenosis, and normal flow, all was already discussed in lecture 9. You can go back to that to it if you are interested. I will stop here. Next lecture will be around LV pathologies. Thank you very much.